So tonight, so for the next 45 minutes or so, I'm going to explore different aspects of sexual health as it relates to breast cancer. And this is actually my favorite topic to talk about. I love this topic. I'm very passionate about it. And what I'm going to do is give you some tips from my experience working at the BC Cancer Agency Sexual Medicine and Menopause Clinic. So what I'd like to do today is to really dispel some common myths around menopause after breast cancer and around sexual health after breast cancer. I'd like to promote and provide you with an informed, evidence-based, but positive approach to sexual health. And I'm going to give you some tips on how you can advocate for yourself. So first, I'd really like to emphasize the importance of sexual health for many people. And sexual health is actually so important that the World Health Organization put out this statement. They said that sexual health is fundamental to overall health and well-being of individuals, couples, and families, and even communities. And we know that the incidence of altered sexuality in cancer survivors is really high. It's long lasting and it can significantly diminish quality of life for both the cancer patient as well as their partner. So this is a really important aspect, I think, of cancer care. So this actually surprises some people. It probably may not surprise you, but we know from a lot of research that 80% of breast cancer patients will experience sexual dysfunction both during and after treatment. And this, I do a lot of educational talks for physician and nurse groups, and this is actually the expression that I sometimes see. A couple of years ago, I spoke to about this topic at a nursing conference, and there were so many nurses who came up to me afterwards who just manage breast cancer patients, breast cancer chemo radiation, and they were so surprised that 80% of people would be experiencing sexual dysfunction. And they told me in their many years of their career, they have never talked about it to a patient. And hopefully that talk changed their practice. So we're actually seeing a lot more people advocating for themselves. And these are some of the headlines that we see in news articles and in magazines. So how to talk to your doctor about sex when you have cancer. Cancer and sex, why is nobody talking about it? And how I got back to being intimate after cancer robbed me of my vagina. So I think we're definitely seeing a lot more advocacy and awareness around this topic. So how are we doing? Well, you probably know that overall we're not doing very well. There have been multiple studies that have shown we're not addressing this well. And this is patients raising their concerns and questions, but also providers, so doctors and nurses, not asking about it. And just to give you some numbers, I'll tell you about a study that was done last year. It was not on breast cancer, but it was on gynecologic cancer, where they interviewed 250 patients who had gone through cancer treatment. 90% of that 250 felt that they should have been asked about sexual health at any time during their treatment. So the beginning, the middle, the end. But over 50% said that they had not been asked about sexual health in even many years since their cancer treatment. But of that small percentage that was asked, 90% found it helpful. So this is an area where we, the physicians, nurses, your healthcare team, can really have a significant impact. So why aren't we doing well? So we can divide these barriers into what I call patient-centered and provider-centered. So let's look at some of the patient-centered barriers. These can be self-centered. So this may be someone's belief about their own comfort, their ability, or even their perceived responsibility in discussing sexual health. So this may be things like someone saying, I wouldn't even know where to start. I don't have the words. But it can also be the patient thinking about provider-centered barriers. So these would be things like worried about their doctor's reaction to discussing sexual health. They fear that their provider may react negatively. They worry about offending or worried that their provider may become embarrassed, like the photo that I have right here. But then there are physician barriers. So we have really short appointments with people, and you may feel this yourself that your appointments, you're kind of in and out. You may feel that you're rushed through, and it is because of these limited resources, limited time constraints. But there's also limited knowledge and training. Certainly, when I was in medical school, that was many years ago, I didn't receive any education on women's sexual health, nothing. Even when I did my gynecology residency, so a gynecology residency is 5 years past medical school. In those 5 years, only focusing on women's health, I had half days, 9 half-day clinics focused on women's sexual health. And that involved sexual pain, menopause, vulvar conditions. It covered a lot of conditions. So even a OBGYN residency is not good at training people on sexual health. And I feel that this is shifting a little bit. But then I've certainly seen a lot of providers have assumptions about patients' sexuality. So these are unconscious biases around things like age. At a certain age, sexual health is important around different cultures, about maybe having a metastatic cancer or being in palliative care, that sexual health isn't important. A couple of years ago, when I was setting up one of my clinics, or when I was expanding my clinic, I now do a half day a week with the gynaecologist. So those are the people who operate on uterine cancer, ovarian cancer. They run a full day clinic, but I could only be there for half a day. So when I was setting up my half day clinic, many of those physicians and nurses said, well, we'll have to make sure we put the younger patients in the afternoon when you have your clinic, because those are going to be the ones that are worried about sexual health. And so that's an unconscious bias that I've seen, and that's definitely not always the case. I've definitely seen couples in their 80s and their 90s. I've seen people who are in palliative care who have really prioritized and valued sexual health, and I do think that's important to be aware of those biases. So when I'm giving talks to physicians and nurses, one thing that I really emphasize to them, and I think this is good to really remind everyone, that many people don't have the language to discuss sexuality. When we were taught sex education in high school, it's all about STDs and about how to put on condoms. No one is talking about sexual desire, talking about arousal, talking about orgasm, talking about pain with sex. So where is someone going to learn about that? Many people don't have that knowledge, and many people also don't have the confidence. There's a lot of shame and embarrassment around, particularly around women's sexual health. So these are things to keep as a reminder. And if any of these things resonate with you, that's very common, and it's very, very normal. And it would be very expected. So let's get into some of the different issues with sexual health that I see. So it's really important to take what I call a biopsychosocial approach. So these are looking at things like biologic, or kind of the medical, physical factors, the psychology factors, and so emotional, mental aspect. But also we need to take this into context with the sociocultural factors. So that's how society views women's sexuality and people as a couple. So specifically, what do I mean? Let's break these down. So specifically related to cancer or breast cancer, the biologic things that I see impacting sexual health are a sudden onset or a worsening of menopause. And this can be related to medications, particularly aromatase inhibitors. Could also be if you've had both ovaries removed, either preventatively with BRCA, or if you've had ovarian cancer. And I do like to provide a little bit of information on how the aromatase inhibitors work, because this is what I see causing a worsening of menopausal symptoms. So when women go through menopause naturally, we see a decline in estrogen and other hormones being produced by the ovaries. But women who go through menopause naturally, they still have a little bit, a minuscule amount of estrogen that's made in their fatty tissue, so in their adipose tissue. When you are put on an aromatase inhibitor, it prevents the production of estrogen in your fatty tissue. And so that's why we can see a worsening of menopausal symptoms. Even if someone's in menopause and then they're put on an AI, it can cause all of their symptoms to worsen. You can see things like hot flushes affecting sexual health. This can lead to sleep disruptions, either due to the hot flushes or just menopause. And we know that sleep is very important for a healthy sex life. There can be mood changes like irritability, depression, anxiety. There can even be rapid cycling between those emotions. We'll see a weight gain when women go through menopause. And then we see something that I'm going to talk about a little bit more. It's called vulvovaginal atrophy, or the newer term is called genitourinary syndrome of menopause. And this is where people can get dryness in the vulva and the vagina, can even be so dry that it causes painful sex. And that's what dyspareunia is, painful sex due to friction, a rubbing sensation. But you can also have discomfort from the surgery, from the radiation from breast cancer. There may be also be lymphedema. There may be maybe previously the breasts and the nipples were part of the erogenous zones, and now there's a change in sensation, or maybe it feels irritated to touch those areas. So these are some of the physical aspects of that can impact sexual health. From the psychology and the societal perspective, we can see acute and chronic stress. So dealing with a diagnosis of cancer, dealing with the treatment, the side effects. There can be an impact on body image and sexual self-esteem. There can be a relationship stress. Also, for many people, this may be the first time that someone in the relationship has been a caregiver, and that can change the sexual roles and how people feel sexually. There can be anxiety, depression. There may be an impact on fertility and grief around a possible loss of fertility. And then there's always a fear of recurrence, and even that can impact sexual health. But then we have all of these societal views, culturally imposed beliefs on the roles of a woman in a relationship, and how that should look, and lots of views on how kind of the standard of how women should look, what we see in our society as being a beautiful woman, and that can shift following cancer treatment. So what I'd like to do is dive even a little bit more into some of the specific things that I see. So I'm going to start off by exploring the vulvovaginal atrophy, so the genitourinary syndrome of menopause. So that can be the painful sex. And then I'm going to go from there and lead into how that can impact desire, some things that you can do there. I'm going to tie in a little bit around mindfulness and being present during intimacy, and also bring in a little bit of body image and sexual self-esteem in the end. So let's start with the vulvovaginal atrophy. So this, as I've already mentioned, when you're in a natural menopause or on an aromatase inhibitor, your body has a significant decline in estrogen. And estrogen is what makes the tissue healthy, makes it feel moisturized, stretchy, pliable, elastic. And so when estrogen is diminished, it can lead to the tissue in the vulva and the vagina being thin, irritated. When you're engaging in insertional intercourse, you can feel friction, rubbing, and dryness, and that can lead to pain. So one of the things that's really important for people who are in menopause is to use lubricants. So I call this in the moment. So these are going to be things that you use during intimacy. And definitely all lubes are not created equal. The most common lube that people use are water-based lubes. So if you went to the drugstore, the majority of lubes on the shelf would be water-based. But in this situation, menopause, I invite people to explore other types of lubes like silicone and oil-based lubes. And the reason why is because water-based products have two properties that are really important to be aware of. One is pH and one is osmolality. So that kind of takes you back to high school science. But many of the water-based pHs are either really acidic, so they're very low, or the pHs are really high, so they're really basic. And you can imagine if they're acidic, when you're putting that on tissue that is irritated, it can cause stinging and burning. But more importantly, the majority of water-based lubes are what we call hyperosmolar. And what hyperosmolar means is when you put that lube or that product on the skin, it's actually going to draw water out of the skin. So, and that's not what we want when the skin is already thin and dry. We don't want to put a hyperosmolar product on there. And most of the companies don't actually publish the pH or the osmolality. So just to play it safe, really try exploring the silicone and oil-based lubes. Some things to keep in mind, you just have to use a very tiny amount, way, way, way less than the water-based products. And the other thing to be aware of that they do stain, so just be mindful of that. So a really common silicone-based product that people like, it's called Uberlube, and the same name as the car, and you can get that online. But a lot of people really like coconut oil and the cooking coconut oil that you just have in your kitchen. Coconut oil is also really lipophilic, so that means it has fats that get absorbed into the skin. So it also acts as a moisturizer quite well. So I'd invite you to explore those. So those are in the moment things to use. But what about maintenance or prevention? So these are going to be things that you use on a daily basis. So these are not going to be things that you use once or twice or just when you're having sex and they work well. These are things that you need to use on a regular basis. And I'll show you some brands that I do like. But the ones that you want to look for are the ones that contain hyaluronic acid. And everyone seems to be familiar with hyaluronic acid because dermatologists have it in other products for the face. It's really good for wrinkles, but it's really good as a moisturizer in the vulva or the vagina. So some of the products you may be aware of. The one on the left is called Replens. That is what I see by far the most common one that's used. It does not have hyaluronic acid in it. And I actually really don't recommend that people use this because the pH of Replens is 2.8, so it's very acidic. The pH of the vagina is around 4. Replens is also extremely hyperosmolar, so it's going to, in the long term, dry out the skin. So I really advise people not to use that. The ones on the right-hand side are ones that have hyaluronic acid in it. The Repagyne, you can see at the top, that's a suppository, so it's going to go inside the vagina. The Gynaecologist and Feel Amazing actually also have vitamin E in addition to hyaluronic acid. They're both creams. Gynaecologist you can get at Costco, and Feel Amazing you have to get at Pure Pharmacy. So there's a lot of Pure Pharmacies kind of in the Lower Mainland and the Valley. It's their own that they make on site. Just if you're not able to take notes during this session and you're looking for this information afterwards, I'm going to show you my website. So this is my center's website. We're at the BC Center for Vulvar Health, and we do have in our patient handout section, we have some information on breast cancer and sexual health that has all of that information in there. So on my next slide, I'll give you a heads up. I'm going to show you a picture of the vulva. So just so you know. So this is a photo of the vulva. And the reason that I show people this photo is because a part of the vulva that is impacted by low estrogen is this part called the vestibule. So if you see out here where the arrow is pointing to the vestibule, that's on the inner labia minora, or the inner smaller lips. That is right at the vaginal opening. Many people think it's inside the vagina, but it's actually not. It's the vulva. And this is actually the place where the majority of women will have their sexual pain. So they'll feel that tightness, they'll feel a stretching at the vaginal opening. And so the reason I show people this photo is because that's where you treat. And so going back to these hyaluronic acid products, I encourage people to explore either Gynaetroph or Feel Amazing because it comes as a cream. And so with the creams, you can put a little bit at the area where you're getting the pain. So if that's at the opening, because if you use the Repagyne, that's a suppository, and insert it into the vagina, I find for the majority of people, it doesn't moisturize the vulva. So just some things to keep in mind. So when you see on the news, everyone, or in magazines, everyone's talking about the vagina, they actually mean the vulva. So let's get into something a little bit controversial. So what if those moisturizers don't work? What if the lube doesn't work? What if the hyaluronic acid products don't work? Is estrogen therapy an option? So it actually is. But this is the face that I sometimes get from some physicians, from some patients, where they think about breast cancer and estrogen are absolutely contraindicated. And that's not actually true. There are many statements put out by different societies. The two I've shown you here are the American College of Obstetricians and Gynecologists, and there's the one below that is from the Society of OBGYN of Canada. There are also from multiple menopause society statements that say start with non-hormonal products, but if the non-hormonal products don't work, it is really reasonable to consider topical estrogen in women following breast cancer. There's a lot of data that shows there is not an increased risk of cancer recurrence among women currently undergoing or treatment for breast cancer. So what I usually do tell people, though, in medicine, when we are looking at the gold standard research, the type of research that we want are what we call randomized control trials. So that's where you take a huge group of women who've had breast cancer, you divide them in half, and you randomize half to receiving estrogen in the vulva and the vagina, and the half are going to use a placebo. So maybe like just some lube or some cream, something that doesn't have hormones in it. And you follow them for years, like 10, 15 years. But when I'm talking about the research for this statement, we don't have that type of research. So we don't actually have the gold standard research. But what we do have is what we call retrospective data. So that's where we've looked back over 10, 15 years at women who have chosen to use vulvar and vaginal hormone therapy following breast cancer, and they followed them for 10, 15 years and has not shown an increased incidence in breast cancer recurrence or mortality from breast cancer. So what are the options? So the options for topical estrogen, these are the ones that we have available in Canada. The one on the left side is the S-string, and that's a ring that goes inside the vagina and it stays there for, you change it every 3 months. And then in the middle, we have the Vagifem, which is a little tablet that is inserted into the vagina 2 times a week. Just last year, or maybe 2023, Imvexxy came on the market. So these are suppositories that you can insert inside the vagina. They come in slightly lower doses than the Vagifem, which is 10 micrograms. So Imvexxy comes in 10 micrograms and 4. And then on the right-hand side, we have the estrogen creams. I have to say, I do have a tendency to use the creams a little bit more because I do find that most of my patients with sexual pain have pain at the vaginal opening. So if you're using the S-string, if you're using the Vagifem, if you're using Imvexxy, it may not get down to the vaginal opening. So I want to treat the place where there's pain. So what I will also tell you, something that I do a little bit differently from other people, if we look at what's available around the world, in Canada, we have two different types of pre-made estrogen cream. In the States, they also have two different types. We have something called Premarin, and Premarin is made from, it's synthetic estrogens made from pregnant horses' urine, actually, which I always make sure I tell patients in case they're vegan, vegetarian, or just opposed to that. And then we have something called estrogyn in Canada, which is made from a medium potency estrogen. In the United States, they have Premarin and they have something called estrase cream, which is estradiol, which is the most potent bioidentical estrogen. Everywhere else in the world, in Europe, in Asia, in Africa, they have pre-made estrogen of the weakest estrogen, which is called estriol. For some reason, in Canada and the US, we don't have this. So I do have to say I will compound this for my breast cancer patients. So I compound it in a bland base, and I make it exactly as they do in Europe. And I'll just have women use a little bit at the vaginal opening. And I truly find just a little whiff of estrogen is all that they need. And most of those studies I talked about was actually done with Premarin cream. And Premarin is the most potent estrogen that we have available. So there was safety with the most potent estrogen. I still like to use the weakest one. So I see a lot of people in my clinic who have trouble getting hormone cream if that's what they want, or getting help for the painful sex, so for dyspareunia. So I always find it helpful to touch on some tips on how you can advocate for yourself. Particularly around menopausal symptoms, I'd recommend going to this amazing resource. It's called the Menopause Foundation of Canada. And under the resources section, which I put an arrow there, they have different things that you can do before you go to see your healthcare practitioner. So they talk about, number one, track your symptoms. And they have a symptom tracker chart that you can download so that you could very clearly have your symptoms outlined. They have the second section is on learning. So they provide some of the research and the guidelines that I've already mentioned. Those are for you to review, maybe print out and bring to your appointment. And then they talk about preparing for your appointment. And they even give you some different words, some phrases to use with your healthcare provider. You can say, I really like this one. I wanted to learn more about my symptoms, so I went looking for some evidence-based research, and I wanted to share this with you. And you can have it there with you. And then lastly, if you're not able to get the information that you want or the help that you want with your primary care provider, they have information on how to ask for a referral. So something like, I really appreciate this conversation. It's given me a lot to think about, but I'd like a referral to a menopause specialist as well. And Dr. So-and-so is someone I'd like to see. So where do you find who sees menopause, who sees menopausal patients? There's a great website at the Menopause Society, and they have a section on finding a menopause practitioner. And there is, and this is international, so you can find out in British Columbia who practices evidence-based menopause and who has passed an exam to give them that menopause specialist credentialing. And in BC, I looked recently, there was actually four pages of providers in British Columbia who provide menopause care. So let's move on from the painful sex. And I find that many physicians, when they're treating painful sex, they sometimes think, well, I've given someone the Gynatrove or I've given someone estrogen, the painful sex is resolved, we fixed it, so everything must be perfect. And this is kind of an expression that I see many times around that question or that issue. And what I sometimes find is yes, giving someone estrogen, giving someone Gynatrove, definitely, and if it decreases the pain with sex, they may be very, very happy. But there are many people who still talk about having a low sexual desire. And what can we do here? So what I find really helpful when I have someone who has low desire is to go through how desire works, particularly in women, because it's a little bit different from what we see in the movies, what we see on magazines. So in the movies and magazines, we see desire or sexual libido, sex drive, as this spontaneous craving or urgency that just comes up out of the blue. And like, you open the door and there's like a good looking, pizza delivery guy there. That never happens in real life, that you have that spontaneous urgency or that craving. But that's how it's portrayed in the magazines, that then leads to the sexual encounter, it leads to orgasm, and then everything is great. And in reality, that's not how sex drive works for many women. So let's go through what we call the sexual response cycle. So rather than starting from a place of being of craving or urgency, most women actually start from a place of being neutral. And by neutral, I don't mean apathetic or numb. I mean open, willing, receptive. So maybe I'll be sexual, maybe I won't. They're open. And then depending on their reasons for intimacy, and we sometimes think that the reason for sex is to have an orgasm, and that's not actually the case. There are many people who engage in intimacy to be physically close to the partner, to feel an emotional connection, maybe as a stress relief. There's lots of reasons. There was a study done many years ago by a Canadian researcher who was interested in the reasons that people have sex. And in this study, they actually came up with 237 reasons. So there's a lot. Then, depending on the environment. So, is the environment safe? Do you feel that maybe your children are going to come in? Is the environment romantic? What makes you feel sexy? And is that the lights on or off? Is that in a comfortable room or an exciting part of the house? Is there, candle, music, whatever you like, whatever makes you feel sexy. The brain looks at all of this information. So the brain looks at, are you starting from neutral? Are your reasons positive? Is the environment romantic? And your brain decides if you're going to turn the corner and experience arousal. So that's the physical and emotional arousal that comes with intimacy. And then at this time, this is where desire comes into play. So desire didn't start the encounter. Desire arises during the encounter. And this is the desire to continue being intimate in the moment. Then, depending on the outcome, is the outcome painful or pleasurable? Were your reasons fulfilled? It leads into you being neutral the next time. So let's interrupt this cycle a little bit. Let's say if the outcome is painful. Then what we see is people start doing things for more negative reasons, like duty, obligation, fear, shame. We see a lot of people will skip those things that make them feel romantic, skip the stimuli, won't put work into creating that sexy environment. They'll also may skip that arousal. And for many women, that what comes with arousal is the external genital stimulation. They just want to get it over with. Then if arousal doesn't happen, desire will not occur. Those two are very, very intimately linked. So there's going to be less responsive desire. The outcome is going to be even more painful because arousal pathways in the body actually compete with pain pathways and help to decrease pain. And what we see is a development of aversion or a sexual avoidant cycle. So our goal with sex therapy is to get back to a place of neutrality. So being open, willing, receptive. We won't be able to create spontaneous desire. Spontaneous desire exists for a very small percentage of people. And at this time, I usually have people tell me, well, at the beginning of our relationship, I had it all the time. And I would challenge that a little bit. When you think of the beginning of a relationship, let's say you and this person you're dating, you talk on Monday, and on Monday you decide on Friday you're going to go out for dinner. So at the time of your conversation, you were starting from neutral. And then during the week, you start to think of all the reasons you want to see this partner. You're looking forward to seeing them. You're thinking about stimuli, the environment. You're doing your hair, getting, some sexy underwear, getting some certain perfume. Your brain is being primed. And by the time you show up to dinner, on the Friday night, you're actually entering it from a place of arousal. So you're entering it into a little bit further along in the cycle. So what do I do for low desire? So I spend a lot of time going through this cycle with people, and I find providing that education is really, really important. And there are many people, when they learn the difference between responsive and spontaneous desire, and learn that responsive desire is common and normal and healthy. For many people, that's actually all they need. But providing that information is really important. As I'm going through this cycle with women, I get them to identify what part of the cycle resonates with them. What's really standing out? What do they have the capacity to address right now? What do they want to, where do they want to start? And for some people, you think addressing the outcome, so making sex less painful would be the obvious place to start. But following cancer treatment, that's not always true. There are many people who feel very medicalized. They feel so poked and prodded. They feel dissociated from their body as a source of pleasure, and they're just done, and they don't want to put anything in their vagina, anything in their vulva. And they also don't want to do it by themselves. So they'd rather address somewhere else in the cycle and maybe address things as a couple. And we can always come back to the painful sex at a later time. So I do encourage planned communication with partners. So there's a lot of research on couples who've been together for decades, and they report being sexually healthy. So they're in their 70s, 80s, 90s. Researchers are always curious, what's that magic ingredient? What is it? And what comes out consistently is that these are couples who talk about sexual and physical health with each other, and they prioritize it. So they plan it. If people don't talk about sexual health and leave it to be spontaneous or natural, they may not do well long term. So we really encourage communication and planning with your partner. And by planned communication, I mean, so I usually in my clinic is on a Friday. So I usually tell people, when you're going home or tonight, don't spring all this information on your partner. Why don't you set up a conversation on Sunday or Monday at a certain time? Tell your partner the agenda for that conversation. So maybe let's spend 15 minutes talking about how we want to be physical during the week. And so your partner has the agenda, the conversation has not been sprung on them. You come together and you maybe come up with some things, some ways you want to be physical. So that's what I mean by planned communication. There's some people who want to start with shifting. They're exploring the reasons for being intimate and shifting from avoidant to approach reason. So shifting from that duty, obligation, fear, shame, to maybe thinking more of, I want to be emotionally close to my partner, or I love the way my partner smells, or things like that. And for some people, they can come up with things themselves. But one of the psychologists on my team went through that big study, that one where they found 237 reasons, and they pulled out all the positive reasons. So we have a handout that lists all the positive reasons so that people can go through those and maybe come up with some that they resonate resonate with. And maybe they can do that themselves. And then maybe they'll put a sticky note on their mirror. Maybe they'll put reminders on their phone that will come up to remind them of the positive reasons. Because what you want to do, I describe these negative reasons as like a groove. It's a groove in your brain. It's an automatic thought, thinking, duty, obligation, fear, shame. If you imagine a field where a pathway goes through this field, and that's that negative groove. You want to create a new pathway. So shifting the pathway a little bit to the right, a little bit more to approach. And it's just going to require some work to create a new, more positive groove in your brain. So what I'm going to do a little bit, I didn't really talk about this processing part, but this is a really important part. So I'm gonna pull this out, and we're gonna dive a little bit more. So what do I mean by brain processing? So if your brain is in a state of stress, most women, when their brain is stressed, they move away from sexual health, whereas men are more commonly the opposite. When they're stressed, they may move towards it. Anxiety, depression, if they're active, can affect the brain wanting to engage in arousal and sexual intimacy. Fatigue, sleep is the one of the most important factors influencing sexual health. If you have pain, it can influence how your brain is going to view all of those cues. If you have other medical conditions unrelated to the cancer diagnosis or treatment. But what I'd really like to focus on are these distractions and judgments. So distractions come up frequently for women during sexual intimacy. And I think I usually see a lot of smiles and head nods when I talk about distractions. So many women, when they're being intimate, they're not present in the moment. And quite commonly, they'll be thinking of other things. Women are really good multitaskers, and they'll be thinking about, maybe they'll see the laundry on the floor and think about how they need to do that before they go to bed. They think about the email they need to send, the stuff they need to do for their kids before the morning, think about plans they need to make for the weekend. Um, Many people are not present during intimacy, and I'm going to give you some tips on how to engage that. Judgments also come up a lot, so these are more negative. So judgments are how you perceive yourself during sexuality, or your sexual self-esteem. And commonly in in sexual medicine, we have something we call spectatoring. And spectatoring is when you're in a sexual encounter with someone, but you, in your mind, are visualizing how you look from above. So it's as though someone's a spectator in the corner of the room and they're watching it. And that's what you see in your mind. And usually it's people being very critical about how they look, maybe their weight, maybe if they have scars, if they have swelling or lymphedema, if how they're performing during sexual intimacy is really, really common. So this is where I'd like to bring in a mindfulness practice. It can be really important during sexual health. So there's been a lot in the popular press on mindfulness, kind of touting it as the answer to everything, and maybe not everything, but I am a big advocate for mindfulness. I think it's really, really important. So mindfulness, what is the definition of mindfulness? What does this mean? So it basically means being present in the moment without judgment. And there's been many studies that have shown that mindfulness practices impact sexual health. So we know that sexual desire is really closely related to internal thoughts. And I've touched on those a little bit. And these can be some of the habitual or those automatic patterns, like the anxiety associated with negative or disappointing past experiences, sexual inhibitions, negative emotions, low self-esteem, and stress. All of those things impact sexual desire. Lots of research showing that practicing mindfulness leads to significant improvements in sexual distress, sexual function, and sexual satisfaction. So, and what is sexual? What does this mean in relation to sex? Well, sexual mindfulness is about paying attention to the present moment. So, not thinking about the emails, not thinking about what you have to do. And it's with intention and purpose. So, it requires work, requires trying to make this a habit and being without judgment in the moment. So, being present to what is happening during intimacy and accepting the moment as it is. So it sounds super easy, right? It's not. So there's a very, very tiny percentage of people where mindfulness is innate, where it's natural. The vast majority of people, it's a habit or pattern that they need to cultivate. And so, one little tip that I would have for someone is to start outside of sex. So, practice mindfulness in your non sexual life. And if you've ever taken a mindfulness course or something called an MBSR course, mindfulness based stress reduction, I think you'll understand why I have the raise in there. So, in that course, they near the beginning of the course, they talk about mindful eating. And this is a really easy way to start a mindfulness practice. So they use a raisin. They have you being present in the moment. So where there's no distractions, the phone is away, everything's turned off. If you breathe and settle in and ground in the moment. And then while you're kind of holding the raisin, they get you to engage all your senses. So the sense of touch, so feeling what does the raisin feel like? It's kind of squishy. You can kind of fold it in half. Bring the raisin up, smell it. What does it smell like? Taste the raisin, hold it in your mouth, savor it, kind of identify the texture, the taste, follow it as you swallow it down your throat. So that's a really simple way to introduce mindfulness around eating. You can do mindfulness with a meal. But one thing to incorporate is during that time, you may have some thoughts that come up, maybe critical thoughts, maybe kind of like, oh, this is really weird. I don't know why I'm doing this. And it's really important to recognize those thoughts and let them float away. So kind of bring your attention back to the present moment. And one thing that they'll teach in a mindfulness practice is almost like watching your thoughts. You're on the bank and you watch your thoughts go down the river. So recognize them, that they're there. Don't try to avoid them or push them away. Let them float away and come back to the present moment. So that's one way to start with mindfulness. We are very lucky to have a psychologist in at UBC, so in Vancouver. Her name is Dr. Lori Brotto, and she is world-renowned research psychologist around mindfulness and sexual desire. She's a huge advocate for this. She wrote a book called Better Sex Through Mindfulness, and just last year she came up with a workbook to guide you through this. This is a really easy to read book. It's very applicable to kind of your day-to-day life, so mindful living, but also in relationship to sexual health. So I'd encourage you to explore that. I've also put her website there. She has mindfulness recordings there that are open access, and I put some Instagram accounts that also advocate for mindfulness practices as well. At this point, I do want to also share a research study that she has on the go. It is right now just for people who have gynecologic cancer. So those are people who have had ovarian, uterine cancer. But why I'm putting this here is because even though it's a research study now, it will soon be available to everyone. And it's something that Dr. Brotto is developing called eSense. This module here is on eSense Cancer, and it is basically an online health intervention that is self-directed. So there are different modules that guide people through different aspects of sexual health, where sexual health become an issue, become a problem, and things that you can do to navigate this. So if this is something you think you're eligible for, I'd encourage you to participate now as the research study. If not, keep an eye out for eSense Cancer, and I think that'll soon be available to everyone. So just lastly, I do want to explore a little bit on, I talked a little bit about how judgments can influence desire. So I'd like to touch a little bit on body image. This is something that comes up a lot on post-cancer cancer treatment. I see this with breast cancer patients. I see this with head and neck cancers. I see this with vulvar cancers. I see this after people who have permanent stomas, after like certain types of bowel cancers. So what is body image? There are a lot of different aspects of this. So it's how you see yourself when you look in the mirror, or the image that you have in your mind about how you look. It's what you believe about your appearance, how you feel about your body, and how you sense and control your body as it moves. So, what influences body image? So, there are three main things that influence body image. One is the identity. So, this is basically how you view yourself. And some of those beliefs come from someone's upbringing. They may be reinforced by society, including your social networks, social media, a lot we're seeing now, as well as your peers. It may also be fostered by your own experiences, your accomplishments, and your lifestyle. And those ideas about yourself are very strongly held, but they do affect how people cope and adjust to breast cancer. So the surgical changes and menopause. Then there's the previous investment in physical appearance and health. For example, this can be how much emphasis you placed on physical appearance or how much it plays a role in determining your happiness, your satisfaction, and your well-being. So someone, potentially something I've heard is someone was maybe really meticulous about exercise and healthy eating. They may feel betrayed by developing cancer. They may feel that their body has failed them. May also be devastated after treatment if you're unable to return to pre-treatment body shape or level of physical stamina. That can also affect how someone can move forward. And lastly, I've already touched on this, it's the stereotypes that we have about femininity and what is attractive. And there's a lot of cultural and societal influences that shape how women think about and view themselves. And it strongly affects how we feel about our bodies. And these influences can set kind of this standard of what we consider beautiful or ideal. It may even be, aside from society and culture, we are also influenced by friends and family in really, really little tiny ways. So you may have experienced this, maybe if a friend or a partner only comments favorably on your appearance when you put makeup on, or if you have your hairstyle professionally, that over time can contribute to the stereotypes about femininity. And sometimes we'll see that women who identify with those traditional notions of what's attractive sometimes feel a sense of loss or shame or failure when they can't return to that level. So when body image is impacted, some of the things that we may see is that you're inspecting or constantly monitoring your body, constantly comparing to past self or what we see on TikTok or Instagram. You may avoid looking at yourself in the mirror. Be really critical about not being able to return to normal activities and feeling that you're not where you should be. So what are some things that you can do to move forward? So definitely one of the things I talk about a lot is just taking time. People put a lot of pressure on themselves as soon as they've done treatment that everything should be back to what it was like before. And it can take time to just to recover, to heal. And I really think this is a time that a gift that people need to give to themselves. I think it's also really important to intentionally identify what messages you have internalized from society. And so this for these types of activities, I would recommend you to kind of journal about these. So be really intentional about coming up with answers. So really identifying what are those harmful messages from society, maybe from friends and family about the female body, and thinking things like, how do you feel about them as you reflect? Do you think, have they now or in the past put pressure on you to conform in a specific way? Questioning, is there one right body type? Or do women's bodies need to be constantly fixed, altered? So just really consider what those messages are that you've received. And it can also be really helpful to think about those in a really critical way and reflective way. So thinking about, what have you learned as you've gone through the breast cancer journey? What strengths that maybe you didn't know you had before? What did you learn about yourself? What do you value or want now? And what does femininity or beauty mean to you? And what do you find is important now in bringing you happiness? So those are exercises you can do over time. And maybe those are things that shift if you visit those questions once a month, once every few months, and do those shift. Next is trying to find ways to actively engage with moving that maybe you hadn't before. So some examples may be doing yoga, doing meditation, doing mindful walking, which I love, being out in nature, being really present. So maybe going by yourself or with a dog, a pet. And so you're not with a friend, you're not talking, but you're by yourself, and listen to your feet on the ground. Listen to the sounds in the woods. What are the smells? So that's a way you can practice mindfulness and being present. But one thing that I spend a lot of time talking about is self-compassion. I find people are really hard on themselves and really mean to themselves, and they speak to themselves in a way that they would never speak to a friend. And so I'm just going to end here with these are two books that I love. I have them myself. I've read them a few times. They're both on self-compassion. They're written by two different psychologists. And I really encourage people to explore self-compassion and self-kindness in this area. So I'm going to end just with a little bit of inspiration. I hope that with this talk, I've given you a lot of tips and information, increase your awareness. And I just want to say you guys have got this. I'm going to end there. I will. Let's see where.